much for being here for our community conversation on the COVID-19 vaccine. The Community Conversations is a series of programs that the Pikes Peak Library District has done the last year on a variety of different topics. And really our goal for the Community Conversations is to really invite our community to come together to talk about complex issues, current events, and get to listen to a variety of different perspectives. And so this last year, we've held a variety of different conversations, some of which you can find on recordings on our website. We don't quite have all of those. Some of our conversations take different formats where we talk in small groups and so forth. And sometimes we have a panel of experts to share information. So we're very excited to have our panel of experts here with us this evening. And I'm looking, we may have one panelist who may not be able to join us this evening. So if I'm checking, if I look slightly distracted here, I'm just checking to make sure if our last panelist has joined in. But I'm very pleased to introduce our panel here this evening as we talk about the COVID-19 vaccine. We know there's a lot of different information and some hesitancy as well. And so the library really wanted to get a panel together to share some information and share both resources and where to find out more information. So we have a wonderful panel here, and we're so appreciative of their time. We have Dr. Cynthia Hazel. Dr. Cynthia Hazel is a researcher at the Omni Institute, where she leads and supports projects focused on public and behavioral health, with research interest in global health, health equity, and digital health technology. Her husband, Dr. Kwaku Hazel, is a general surgeon and surgical fellow in minimal invasive surgery at the University of Colorado Hospital. He completed his residency in 2019 and has been involved with educating community members in Aurora through churches and community organizations since moving to Colorado in 2012. Both Dr. Hazels are members of the Colorado Vaccine Equity Task Force. Then our third panelist is Dr. Margaret Liu. Dr. Margaret Liu is a world-renowned expert in the fields of vaccine, immunotherapy, gene therapy, and global health. She obtained her MD from Harvard Medical School and completed her clinical and research training at Massachusetts General Hospital. She's also CEO of PAX Therapeutics, which is developing gene-based therapy of tendon and ligament repair. As principal of ProTheramune, she consults for companies, universities, and scientific and governmental organizations. She actually, kind of her tie to Colorado is she did go to Colorado College, so we're pleased that she's still willing to kind of join in events here. And Dr. Liu has been known actually as the mother of DNA vaccines. So we're very pleased to have our panelists here this evening. I'm just double checking if we have, looks like we do not yet have El Paso County Public Health. We know that they've been very busy and very involved in the response to COVID-19. So we will certainly share information about how to get information locally about the vaccine rollout. But again, very pleased to, we're going to go ahead and stop sharing our slides here so we can view our wonderful panelists here. And we are, I should mention also that we are recording this conversation. The recording will just be showing the speakers. So if you are here as an attendee, you will not be on camera. You will not be on the recording, but this will be available after to reach many of our other community members. So first of all, I think we'll start, the first question, and this would be for all of our panelists, is we've heard a lot kind of both in the news and in a variety of different articles about herd immunity. So it would be helpful if you could share what is herd immunity and how many people actually might need to get vaccinated for the US to actually reach herd immunity. And let's see, Dr. Liu, would you like to start? Let's see, it looks like you are muted. So I'm gonna...
Again. Okay, here we go. Great, thank you. Well, I'm really pleased to be here and to participate in this. And I do just want to add just one disclaimer about this, which is that I am on the scientific advisory board of the Oxford Jenner Institute, which did develop one of the vaccines that is being developed right now. And I also am on the drafting group for the WHO group that's writing guidelines for mRNA vaccines. So I won't be talking about anything that's private information, and I won't be plugging any particular vaccines. So herd immunity is an interesting concept, and some of you may be wondering why sometimes there are different numbers that fluctuate. What herd immunity is when enough people are immune to a disease, either because they've already had it and hopefully won't get it again, or because they've been immunized, that there won't be transmission amongst people from people who aren't immunized to people who aren't immunized. What makes it a little complicated for COVID is, first of all, it's a new disease. And so we don't quite know exactly how infectious it is, although it's clearly pretty infectious given the worldwide pandemic. But we don't know how long immunity lasts, whether you've already had it or whether you've had the vaccine. So the thought is that maybe between 70 to 90% of people have had the disease and or been immunized, that will stop transmission. However, I must say though that these new mutant strains that are circulating add another big unknown, because we don't yet know whether people can in fact be protected against all the new mutants, whether they've been immunized or whether they've already had the disease.
Great, thank you very much. That's very helpful. And either of Dr. Hazels, would either of you like to add anything else to?
I definitely want to second what Dr. Liu said. Personally, herd immunity, and also with some people I've heard from, herd immunity is, the term herd kind of gives off a sense that maybe we are cattle or something like that. People who've heard it kind of sometimes have approached me and said, hey, does this mean we are test subjects or stuff like that? So another term we can use is population immunity. I think that term is widely accepted and sometimes might help. With regards to what Dr. Liu said, I do 100% agree that between 70 to 90%, maybe I think most people are quoting 80% right now as as what we need, or the percentage of the population in the US that we need vaccinated before. And these variants definitely throw us a curveball, because if we have variants that are increasingly more virulent or are able to spread even more, that might even raise the numbers even higher in terms of the number of people that need to be vaccinated to achieve population immunity. So I'm sure we'll get to the issue of variants later, but I think that is one aspect of it. The second aspect I think Dr. Liu touched on is with regards to how long the immunity from the vaccine lasts. You know, the first people were vaccinated probably in July of last year. So we are still following the data, testing people and seeing how long the antibodies to the original coronavirus last. And depending on that, we're also gonna know how long, when exactly this herd immunity can be achieved.
Great, thank you. And Dr. Cynthia Hazel, did you have anything else that you wanted to share there? Okay, I couldn't tell there. She was looking to, okay, yes, excellent.
Sorry, Amy, I think you were muted, so I couldn't hear what you were saying.
Sorry.
No worries, but I assumed you wanted me to chime in.
Yes.
Yeah, so on the subject of population immunity, just also wanted to add that there are two ways that we can achieve that. One is through exposure to the disease that we are trying to prevent. And so as more and more people become exposed, that is the natural immune response that is developed in everyone who gets exposed to the disease. And that is through the natural means where everyone now develops antibodies. And so within the population, as more and more people become exposed, more and more people develop antibodies, we can naturally and organically reach population immunity that way. Another means is through vaccination. Now, vaccines perhaps, touted as much better than, getting exposed to the disease, because we also don't want people to assume that getting naturally exposed to the disease is another legitimate way. And so how about I just go and expose myself to the coronavirus and get a natural immune response? You can do that, but through vaccination, we can avoid unnecessary pain and death amongst people who get exposed. And so you don't have to necessarily get exposed as a means for us to reach herd immunity. And so vaccination has been the major way that, at least in the United States, we are hoping to reach herd immunity the more and more people get vaccinated.
Great, thank you very much. And I should say to our audience, we have a few questions that we've prepared for our panelists, but this is certainly an opportunity for you to ask questions as well. So if you do have any questions, please go ahead and add those into the chat, and then we will go ahead and intersperse those and make sure that our panelists have time to answer those questions as well. So again, please feel free to ask any questions that you might have as well. So the next question is maybe, could you share with us about the safety and efficacy of the COVID-19 vaccine? And we do know that there are a couple of different, currently right now in the United States, there are 2 different vaccines, and then certainly with a third and others that are certainly in trial. But we would certainly love to hear your perspective about the safety and efficacy.
Sorry, who did you want to answer this one first?
Dr. Liu, go right ahead.
Oh, okay. I think the most important thing to note is that every vaccine that has published their data in the peer-reviewed literature has shown that for protection against the most severe disease, they're all doing great. And so essentially, even though you read about different numbers, those include people who may have gotten symptomatic infection, but when you look at the most serious infection, they're all essentially the same. And so the most important thing is to know that you shouldn't try to say, oh, this one looks like it's a few % better than that one, because really the most important thing is to protect yourself against the most serious disease. They're all essentially the same. And we don't really know about some of the other differences, such as how long the protection will last and so on. So really, the key thing is if you have the opportunity to get a vaccine, all of them have been shown to be very efficacious for the most serious protection. And they also all are very safe. I mean, some people have, the headaches or tiredness, they may have some side effects, but you shouldn't worry about taking one or the other of the ones. Once they get the authorization by the FDA, then it's much better to be immunized than it is to run the risk of having the disease.
Great, thank you. And Dr. Cynthia Hazel, maybe we'll kind of go in third.
Sure. Yeah, so I'll add that it's important for everybody, to know that in developing these vaccines that there were no steps that were skipped. Just from a public health standpoint, my colleagues and I have been discussing, the name Operation Warp Speed and how that word has generally made people feel or assume that these vaccines were developed in such record speed that maybe some steps were skipped. And so in a few of our community education campaigns, we've had people ask, why did they name it, why did they add speed to the name? And we've had to explain that it's just a name and it doesn't necessarily refer to the processes for developing a vaccine. And so that's just one thing that we try to, highlight and let people understand that true, these vaccines were developed in record time, but that's because of the change in technology and the new processes that were introduced, and most importantly, the fact that a lot of the different clinical trial phases were initiated concurrently. And so initially, or in with other vaccines, what we've done in the past is to just kind of wait for the first phase to be concluded. We gather the evidence, we gather the results, and then start the second phase. What this new technology affords us is the opportunity to concurrently initiate all the phases of clinical trials. So as we are, studying the first phase, the second phase is also ongoing. And at the same time, given the result that is coming from the second and third phase, vaccine manufacturing is also happening. And so all of this coming together ensure that we're able to produce the vaccine, within 9 to 12 months. But it had nothing to do with important skips in the clinical trial being skipped.
Thank you.
If I could just add something to that, because I think you've raised a really important point, Dr. Hazel, and that is that these mRNA vaccines, even though there's been so much talk about them being new technologies and how fast they've been developed, actually they arose in the earliest days in a publication in 1990. And so this is an area I've been personally researching in so-called nucleic acid vaccines. And so it's actually been 3 decades. So while it's a new technology in the sense that there had not been any licensed approved products or drugs, in fact, the research effort and even clinical trials for other diseases have been going on for quite some time. So I think Dr. Hazel made really the key point here is that unfortunately the terminology of calling this Operation Warp Speed made it sound like all of a sudden they just started doing this and they skipped steps. And that's actually not true at all. As she said, what happened was, in fact, some things were done in parallel, like starting to build the manufacturing capacity that normally you'd wait until you had the results because you didn't want to risk financial loss of having invested in manufacturing before you knew if the vaccine worked. So that's not a safety concern for people. It was simply the companies, normally that would be a financial risk for them. And so because of government funding and so on, they were able to go ahead, but it wasn't by leaving out steps. It was simply by taking out some other risks, which were primarily financial risks.
Thank you. Dr. McCoo, yes, go ahead.
Absolutely. So I can also add with regards to the safety of this vaccine in that it's very few people and a very low percentage, way less than 1% of people have serious adverse reactions that require hospitalization. And I know that's a question I get quite a bit. And so the biggest reaction that most medical professionals are afraid of is called anaphylactic shock, where people are not able to breathe and they swell up, and it could be life-threatening. This happens rarely, and what we found out is that people who have this can be maybe singled out before the shot. So we think people who have had previous reactions to vaccines or have serious reactions to other things like peanuts and stuff requiring the use of an emergency drug like an EpiPen are at higher risk for getting these reactions. So with those people, we do say speak to your physicians first and then have a plan before getting the vaccine. And typically when you go to a vaccine clinic, after you've received the vaccine, we ask people to wait for about 15 minutes to be observed. Usually that's when those serious reactions are seen. And with people who've had a history of reaction to another vaccine or a component of the vaccine, we ask them to wait at least 30 minutes to be observed. And on site at almost every clinic, if not all clinics, they do have emergency drugs that can be used to treat this bad allergic reaction if that happens. And we are very good at treating that. So we are not seeing deaths related to people receiving the vaccine.
I think that that's really an important point. And if I could just add to it, the CDC, in fact, nobody has died from the reactions. And they have, the NIH and other groups have looked into this a lot. They think that it is a very specific component of the formulation of the vaccine that actually is a compound that's in a lot of things. It's in toothpaste and shampoos and laxatives and so on. And so what they say is that having any food allergy, like a peanut allergy, or having an allergy to other vaccines does not necessarily mean that you're going to react and have a problem with this vaccine. So while what Dr. Hazel has said is they say, talk to your physician about it, but in fact, having a food allergy is actually not a contraindication because they think that they've identified this component, and it's not a component in other vaccines, even though it is in other things like toothpaste of all things. It's called polyethylene glycol. So that's why they're saying, you know, the disease is so dangerous and it's spreading so much that just because you're allergic to food or even to other shots, because sometimes other shots are made in eggs. So sometimes people have egg allergies. They say that doesn't mean you can't get the vaccine. You should talk to your doctor about it.
Okay, great, thank you. And I think what we'll do, there are a few questions coming in chat, so I'll look at a couple of those and then we'll kind of go back here. So one of the questions is, have the vaccines been tested for negative effects on those who have type 1 diabetes? And maybe I'll let whoever would like to, who feels comfortable answering that, go ahead and go.
Well, I'll take that because I'm an endocrinologist, actually. So, what was done was that when they recruited these 30,000 people for the one study, 40,000 people, and each of these studies had tens of thousands of people, they did, in fact, try to get a lot of people with different conditions. So both being above 65, for example, because older people, I'm almost there, don't make as good immune responses and so on. And they did try to get people with a number of underlying other medical conditions, whether it was cardiovascular disease or whether it were diseases like diabetes. And so, in fact, what is known is that if you have one of these other diseases like diabetes or hypertension or cardiovascular disease in general, or are very overweight, these conditions predispose you to have much more severe COVID if you get infected. So in fact, people do need to get the vaccine, especially if you have these other conditions. They have been tested in people who have a variety of health conditions, and they appear to be safe in them as well. But even more importantly, the risk-benefit ratio means that the risk is so much greater from the disease that the benefit of the vaccine is even greater for people who have other diseases.
Okay, great, thank you. And Dr. Hazels, if either of you have anything to add, yeah, go ahead.
I completely agree with Dr. Liu, and I personally haven't come across any studies that specifically looking at the type 1 diabetes population and the effect the vaccine has specifically on that population. I don't think we've gotten to that stage yet. But more importantly, we know for sure that COVID-19, the disease, is worse and the effects are more serious in people with pre-existing conditions, for example, like Dr. Liu said, cardiovascular disease, diabetes, and obesity. So protecting yourself with social distancing, masks, and hand washing while you're waiting for your turn to get the vaccine is extremely important, especially when you have those conditions. And when your turn does come up to get the vaccine, I'm sure we all highly recommend that you try and access the vaccine.
That's such a key point. And I just want to add this, although they haven't done specific trials where they said, well, let's look at people who have diabetes, they did try to include people with other diseases in the studies. They are now starting to do specific trials, for example, for people who are breastfeeding or, people who may be pregnant or something. So they are trying to expand the studies, but what they had to do the first time around was do it for the general population, but including people who might have other diseases in particular.
Okay, great. Thank you. And we're getting a number of questions, so I'll go ahead and get to the next one here. It says, in regards to herd immunity for people over 65 who have already had COVID and recovered, why are these people being told that they also need to get the vaccine? Dr. Cynthia Hazel, do you want to look like you were going to go there? Yeah. Go ahead.
I can start with this one. So with regards to anybody who gets the vaccine or who has had COVID-19, we so far don't know how long the protection lasts. Some people, initially we said it was 3 months. Some people now say maybe about 6 months, but we are not sure. What we do know is the levels of protection that come about after you receive the vaccines are almost tenfold greater than when with the natural infection. With the natural infection, if you get the COVID-19 and you recover, a lot of the immunity you get is dependent on how serious your infection was. But in general, the vaccine we know for sure has generates a higher level, and the vaccines that are currently being used in the US generate a higher level of an immune response, and it's more specific than the natural infection because it goes after the spike protein that the virus needs to be able to infect cells. So it's a lot more specific, and you have a higher level, and it's a more focused immune response. So for that reason, I think we do recommend that even though you've had the natural infection, you should get in line to get the vaccine. Maybe not as soon as somebody who has not had it and maybe has a lot of pre-existing conditions, but as soon as your turn does come around, and we do recommend that you try and get the vaccine.
Great, thank you. Do either Dr. Liu or Dr. Cynthia Hazel, do either of you have anything to add?
I just would add that I think Dr. Hazel summarized it very nicely. I would just add that a recent study just came out that said that people who'd already had the disease, that after their first injection of the vaccine gave even higher responses. And so that would be one nice thing for those people, since they already suffered the disease. They still should get the second shot. But what it means is that the first infection did in fact help prime the immune system. And now you're getting, the first shot is acting like a boost. And this is very important because of these mutants that are coming up. The higher the response you can have, the better the response. So it's still very important to get that immunization, both doses.
Okay, great, thank you. Let's see, I'll kind of ask, we have another question here in the chat that asks, are vaccines a public health tool or a personal prophylactic? Dr. Cynthia Hazel, would you like to?
Yeah, so vaccines are definitely seen as a public health tool. Now, this is because the effects, the general effect or the end goal of vaccinations is to be able to reach population immunity. Now, I like to differentiate these two because no matter how good a vaccine is, if only a few people within the community are vaccinated, as far as the community protection goes, that you don't have, you just can't reach the levels where the community as a whole has a protection that it needs. Now, the reason we say that is because of how viruses replicate and also get transmitted from person to person. Think of it this way: if there are 100 of us in a community, and each of us take the personal responsibility of getting vaccinated. As soon as we reach herd immunity, what that means is that the virus has nowhere to go. But if just maybe 10 people in that 100, a group of 100 are immunized or are vaccinated, the virus still is able to jump from person to person amongst the people who are not vaccinated. And so as far as there is some personal responsibility in getting vaccinated, the end goal is to have this public health tool, because the community protection is what really does protect us from, and also ensuring that variants don't come up, because the virus doesn't have a lot of replication to do and jumping from species to species. And in that process, some of it resulting in like genetic exchanges that can make it either more virulent, more transmissible, or more deadly.
Great, thank you very much.
I think, can I just add, I think that's such a, that's such a great answer. And this is such an interesting question. And quite honestly, for many vaccines now, the reason people will say they don't want to get the measles vaccine is because they perceive their personal risk of getting it as very low, and they are benefiting from the public health benefit of having so many other people getting it. And so in that case, they really view it as, well, this is a public health tool, but as long as everybody else gets it, I don't have to worry. Now, what they don't realize is that anytime they travel, such as to Europe, where some countries have really low rates of immunization, this isn't just talking about, going off someplace that you think may be really exotic. This is just talking about walking through any airport in the United States or going to Disneyland because somebody went to Europe and came back with the measles. And so in this case, though, people think of it as a public health tool and think wrongly that they don't need to protect themselves personally, whereas in fact, they actually really do, because there is more and more of these diseases that we had almost eliminated. In this case, there's so much COVID out there, and with the risk of the mutations, it is both a public health tool and a personal prophylactic. So in this case, you don't need to feel that you're just doing this for somebody down the street. You're doing this for yourself if you get immunized, as well as doing it for someone down the street. And the same goes actually for masking and social distancing that Dr. Kweku Hazel talked about earlier, because you are protecting yourself and you're protecting other people. So it's really important that both of these aspects are highlighted, that you're doing someone else good as well as yourself.
Wonderful, thank you. So the next question, and I'm going to jump back over here, is why are some individuals and groups hesitant to receive vaccines? And we sometimes particularly see this in communities of color. And then what would you like those who might be hesitant to know specifically about the COVID-19 vaccine? And I think I'd love to hear from all of you, but I know both Dr. Hazels have been really involved in this, so it'd be great to start there.
So that's an excellent question, and it's very important for all of us to understand the reason of this hesitancy. There are different reasons, and I'm going to start with one of the most obvious, which is historical context. So I think in a lot of BIPOC communities, communities of color or historically disenfranchised communities, there's a lot of mistrust of the system, and especially the scientific system, based on history. There's well-documented cases of where science and public health officials and state groups used their influence to mislead, abuse, and mistreat people of color. And some of these could be referenced with the Tuskegee syphilis experiment, in which a group of African-American men were asked to, this was I think in the 20s, a group of African-American men were approached and told that they were being given an injection with regards to possibly treating a disease called syphilis. And but unfortunately, they were actually given the disease and later on denied treatment for the disease when the treatment became available. So what happened is these individuals were misinformed and were being studied, watching the natural history of the disease, even when they were getting sicker and sicker, even even when therapies were available. And then eventually caused some of them to even lose their lives from this. So this became public after just by a journalist or someone who got very interested in this story. And even after it became kind of exposed, people still try to hide it. So with the community, especially the Black community, witnessing, learning, and hearing about all of this created a lot of mistrust in the community. And it's not just historical. I think current issues also play a huge part in the hesitancy. So there are a lot of people who still feel like they are not being heard in the medical community or the scientific community. People of color complain when they go to hospitals, they are not properly addressed, their pain is not taken seriously, their concerns are not heard, and that is ongoing, and that plays a huge part. And some of these stories are not documented in textbooks and all of that, but they travel down generations in families. You hear it from the different families, their friends, different small communities, and so those things really have increased vaccine hesitancy in these groups. I'll have Dr. Hazel also comment on this.
Yeah, I'll just, sorry. Yeah, I'll just reiterate the latter part of Kwiku's submission. That is the current issues we have in the current problem that we have with the medical system. And so I mean, we all know about the historical context, but I think what has been even more prevalent and what has deepened the mistrust that communities have with just the medical community in general is because a lot of people of color know somebody who's had some form of a story when they've visited either providers or have been in care interactions where they feel like they've been viewed suspiciously because maybe they requested certain medications or had certain concerns, or when their knowledge of their own bodies have not been taken seriously in care recommendations. So what that usually or typically does to a person is that if I wasn't listened to the last time, it means that you don't trust me. So if I leave that care interaction feeling like I wasn't trusted, what I tell myself is the way to cope or the way to protect myself next time is to make sure that that interaction doesn't happen moving forward. And so if a vaccine is being recommended to me, how am I going to know that I'll be taken seriously if I'm having side effects and I want to complain about it or I want to bring that concern forward? So it's just also the projection of what could be and not knowing what the outcome of those concerns might be should they happen is what fuels that mistrust. And so people tend to stay away altogether because they just don't want to take on that risk and realize that they are alone in bearing that risk, or they are not going to be heard should that risk be more than they can handle, or if they need help in trying to take a vaccine. So that has been one of the issues we've been dealing with. The second issue that has come up time and time again is generally the mistrust between people who develop medical products and people of color. So one of the issues that came about when Kwiku and I started education is that people were asking were people of color involved in these vaccine trials. Is because just having that sense that people of color or maybe African American groups were included in the trial makes people more comfortable to know that it does work for us as well. Now, historically, this has not always happened, where people know for a fact that some medications that have been developed had clinical trials that were not as diverse. And so there's that confusion whether if this worked on for example, an indigenous person, is it going to work for me as an African American? Or if this worked for a Caucasian person, is it going to work for me as a Hispanic person? And so just not having that information or that transparency around who is involved in testing these trials in of itself becomes a barrier. So we were very excited to know once the Moderna and the Pfizer clinical trials were published and we reviewed, and we saw about, close to 10% of them were African Americans. So we knew that that could be part of the education to let people know that, yes, there were 10% of African American groups included in this, 3% of indigenous people were included. And so just having that as part of the education helped people feel more comfortable, because then it erodes some of that distrust that if we were included, then it is definitely going to work for me.
Okay, great, thank you. And then Dr. Liu, did you have anything to add?
Well, I think they've really addressed the key issues. I think I might just add one thing that segues into another question that I see on the chat, which is that it's that people may not just mistrust because of the name Operation Warp Speed, but because sometimes we are told one thing, like eggs are bad for you or whatever, and then like just recently there's another article that came out and said this or that, and I think that actually adds to it, feeds into it. An example is that it used to be most of the studies for heart disease and for drugs were done on men because of the way, I think because men got their greater than their share of the good health care than women did. And so it turned out that all these women were dying of heart attacks because the symptoms are different and people didn't recognize that the symptoms are different and hormones are different. And so the treatments may need to be different. So now there are key requirements for certain, clinical trials that you need to have them done in women specifically, for example. So you can imagine then that it would be even worse for people of color to not be included because they have been even further, not just not prioritized like the men were prioritized over the women, but even further subject to all of the systemic racism. I mean, I think that the way to think of it is that people talk about health disparities, and actually health disparities is really a euphemism for systemic racism, basically. And so no wonder there are people having concerns about, is this study really relevant to me? Is the outcome relevant? Much less, am I being used as a guinea pig? So I think that there have been, strides made because people have recognized this, but still much more needs to be done, because now we've seen that even though the vaccines have included in their clinical trials people from different racial and ethnic backgrounds, we're still seeing that the rollout of vaccines has this huge disparity then of who's getting them, and that richer, wealthier white people are jumping to the head of lines, including driving into poor neighborhoods and using the vaccines that were specifically sent there for the people who live in those poor communities. So even though I think it's great news that the vaccine trials were done in a way that we can have confidence in them, it's a huge, it's not simply a matter of convincing people of the BIPOC communities that the vaccines are safe. It's that we just have so much systemic inequities that the whole system has to actually be changed in order to help right so many of these wrongs that have just been going on since the country was founded, actually.
Yeah, thanks, Dr. Liu. The last thing I wanted to add is also just generally, when we talk about vaccination hesitancy, that narrative places more of the blame on the people who are hesitant, rather than addressing the issue of why that hesitation is happening. That is the discrimination that we observe from medical providers, the systemic racism that has, fed into why this hesitation exists in the first place. And so, as much as we want to be able to continue with education, reduce or improve vaccine acceptance and reduce hesitancy, that effort needs to concurrently happen with addressing the source of that problem, which is the historic discrimination that people of color and just minority groups in general, face with the healthcare system. And so for me, again, just from, because I'm a behavioral health standpoint, if there is a way to encourage behaviors around, improve behaviors around vaccine hesitancy, we want to be able to also address the behaviors of the healthcare system. So maybe vaccine hesitancy shouldn't be the name that we use, because that just generally places the burden on the people who are affected. Maybe then we have to have a different kind of name that also calls out the medical community to be more accountable to reducing or perpetuating the discrimination and all the issues that arise or that give rise to vaccination hesitancy.
Thank you.
Wow,
very
that's
much.
really powerful. And I have to say, I'm helping organize a talk next week for healthcare providers on vaccine hesitancy. And so I am so grateful for what you just said, because that's just framed it in such a key way. And I'm moderating this session on that. So I'm going to remember and write that down, because that's such an important point. Thank you.
Thanks, Italina.
Well, there's been a little bit of discussion about the variants, that we're starting to see, and certainly, so one question that we have here in the chat is, there are countries that will have a more difficult time acquiring vaccines and getting their populations inoculated. So given the danger that variants pose, how important is it for the US and other wealthy nations to help provide vaccines and other resources to help those areas in need? It seems it would be worth the investment to protect ourselves from the variants that will arise if COVID is able to spread and mutate in other parts of the world.
Yeah, that's a great question. And nowhere is safe if everywhere isn't safe. So we are not going to be safe in the Western world or wherever if Africa or some other places aren't adequately vaccinated. So it's really incumbent on the whole world to really push this vaccine. I know there are efforts at the WHO and all through the COVAX program to try and get vaccines to low-income countries, but there's definitely room for improvement. And the biggest concern being that variants are going to be able to arise if there's uncontrolled transmission or spread in any corner of the world. And we know from the original coronavirus that it just takes one small city or one city somewhere in the world and the whole world can be infected within months, So this can repeat itself, even if we have vaccines for the original coronavirus. And we can see that with the variants that are coming up from all over Brazil, South Africa, and here in the US. In terms of right now, I think a lot of countries are scrambling. There's almost like a vaccine race to get as many doses for themselves and vaccinate their population. And that's because supply has just not caught up with demand. And what we are hoping is as we scale up production and supply is able to catch up or exceed demand, maybe we are able to equitably distribute the vaccine, not only here in this country, but around the world.
Great, thank you. Dr. Liu or Dr. Cynthia Hazel, would either of you like to add to that? Or? I think Dr. Liu is unmuting. So
Sorry, for some reason, sometimes the unmute button works and sometimes it doesn't. I think that Dr. Hazel's really outlined a key issue of until you can take care of everybody on the planet, even if you view it from a purely selfish viewpoint, you're still going to be at risk because this virus, it's an RNA virus, which means it can mutate so quickly. And therefore, and it only takes one airplane ride. I mean, the fact that there is COVID on Antarctica now, is really pretty stunning, because there's not a lot of communication between Antarctica and other countries. And so that's one aspect of it. But the other aspect is just the humanitarian aspect, that like, everybody on this planet, there are brothers and sisters. And so there's no one human life that's worth more than another person's life. And so, there's these two aspects. And one of the key challenges is, of course, that the two vaccines that we're using in the US now require a huge amount of infrastructure and capacity. And so to think of, having to ship these vaccines at minus 80 degrees Celsius is, that's just problematic. And so, but I think that these are the two aspects, is that if we don't treat everybody, then we're just going to be chasing our tails always. And, but at the same time, in a sense, that's not really the most important thing. The most important thing is that we need to care for everyone, because everyone's lives are worth just as much as our own.
Great, thank you. Let's see there, kind of just go back over here to the chat. We have another, it's a long question here, but it says the panel's talking a lot about the positives of the new vaccines, but what about the risks? Every vaccine has risk, and these two vaccines are still only approved for emergency use by the FDA. Can you talk about the person who is high risk for adverse reaction and the person who really should be discussing these details with their personal doctor?
Well, if you don't mind, I'm going to jump in here, because I am on the drafting group at the WHO, and the whole point of this group is helping to write recommendations and guidelines, because not every country actually has an FDA. And so WHO tries to, make sure for the safety of everybody that there are some key issues here. So I think that this is really, really a good point that was brought up, in that what always needs to be balanced is risk versus benefit. And so first of all, you always try to make the risk as low as possible. But you also then have to say, okay, is this a disease that affects 1 out of 1 billion people? Or is it a disease that affects 7.7 billion out of 7.7 billion people? So that's the other side of the equation. But I will say that, one of the nice things about regulating vaccines is that most of the side effects tend to be something you see very early on, because the whole idea is you're stimulating this immune response. So, you're not giving someone a drug that they have to take every day for the rest of their life for decades. And those drugs, it might be that over 10 or 20 years, by having treated with this drug, you might see something. Whereas vaccines, you're going to see most of the side effects very early on. And that's, in fact, what you see. People have fevers, they get really tired, and so on. So this really isn't about minimizing risk. It's understanding what are the types of risks when you go in with any new technology or an old technology, but when you have this new pathogen. And it is true that the fact that these are emergency use authorizations rather than licensure, and because the pandemic is so bad that they're now offering the people who got placebo the vaccine, it does change these phase 3 trials. So they won't have a placebo group or full group to follow for all this time. But the good news about it is that because they made all these companies follow people for a median of 2 months, and of course, in fact, it was much longer than that, because by the time they put together all the data and submitted it and so on, they continued to follow these people. That's actually why people are comfortable with this, given that the risk from the disease is so bad, but also the side effects that we're seeing were generally very mild. And so I think that, in fact, it's a very good idea to always discuss your personal situation with your doctor, because there are just some people who are more allergic to different things and so on. So in fact, that's exactly what this person is suggesting, is in fact exactly who they should discuss it with their personal physician. But understanding the actual data that's come out, because these vaccines have now been in millions of people. And every country like the US, you know, the richer countries all have these systems where you can actually go on the CDC's website and they update the adverse events that people have reported since they've gotten the vaccine. So there's actually even though once they've started getting used, there are 3 different systems that are used within the US for people to report and monitor side effects. And this is very important and will continue to be followed up by the companies, by the FDA, by the CDC. So just so people know, it's not like they said, okay, bye-bye, we did our study, now we're not going to pay attention. In fact, they're still collecting all this data and will continue to collect it for years and respond to it if they see a signal that looks like there's not safety.
Thank you. Yes, go ahead, Doctor.
That's very, very great, Dr. Liu. And I just wanted to add to that when she talked about the risk-benefit ratio or risk-benefit, looking at that, currently in the US, we've had about 30+ million cases of COVID-19, I believe, recorded, and about over 500,000 people dead. We've administered 50 million vaccines to people, and currently there is no death that has been directly attributed to the vaccine. So when you're talking about risk benefit with regards to adverse effects or risk for mortality with the vaccine compared to the disease we are trying to address, it's pretty stark.
Great, thank you very much. And I know we're getting close to our time here, and there's a couple more questions in chat. So if we're okay, we will try to get through these couple of questions here. But really, I know this is a lot of great information and super helpful. One question here is for households with individuals that will receive the vaccine at different priority stages, should the non-vaccinated individual or individuals be worried about being in close and consistent contact with the vaccinated individual? Whoever would like to. Okay, Dr. Liu.
Well, I was just going to say, the only way they would need to worry about being close and consistent contact with the vaccinated individual is if that vaccinated person thinks they're so immune that they can go do anything they want and they don't continue to wear masks, because that vaccinated person is protected from severe disease, but they might still get infected and transmit to somebody else. So they're not at risk to anybody else because they got the shot per se. They're only at risk if their behavior changes and they think that they're now superpowers and that they can go out and do whatever they wanted to do, because they might still be a vector to make someone else sick. And so that's the only reason, somebody who's not vaccinated needs to be concerned, is that they might get it from somebody who themselves won't get really sick because they've gotten the shot, but they still could be infected and transmitted to somebody else.
Great, thank you. Anything else to add from? Okay. Next question here, it's one of our last ones, is do these vaccinations have thimerosal in them? That is a bad word and also causes huge concerns.
No, they don't.
No, and I think this is, some of the helpful information is to understand, right, kind of what's in the vaccines and what people might be concerned about or not. And we've just been continuing to share some resources in the chat for where you can get other information. We'll also, we are sorry that El Paso County Health wasn't going to be here. We were going to talk a little bit about how the rollout's going out locally, as well as how to find local information, but we'll share a few links in the chat so that we can get that information. But let's see, okay, there's one last question and then I think we'll let everyone go. It says, so maybe this is where there might be some information that it says, why do you keep repeating that there have been no deaths when there have been hundreds of deaths from the vaccine as reported in the AERS? We can read those public reports. So would anyone like to speak to that?
So I just like to make the distinction between, there are things that happen to people all the time. And so the issue is every death gets, or maybe not all of them, but the deaths get reported. That doesn't mean that they were caused by the vaccine. So for example, there were cases of Bell's palsy, that 4 cases that happened during the Pfizer trial, 4 cases in the Moderna trial. And those were deemed because this Bell's palsy happens to people anyway. And so it was no greater incidence than would have occurred in the population anyway. And likewise, even it did occur even in a placebo person. So clearly couldn't have been due to the vaccine there. So what's really important when you read the VAERS reports is whether or not they ascribe it to the vaccine. So there have been some cases that they're looking at, such as there was a doctor who got thrombocytopenia a few days later and he died. But that hasn't definitively been shown to be due to the vaccine, but they are investigating it. So I think this is the key thing, is it may turn out that there are some side effects that do cause mortality, but to date, when you look at it, you have to also look at people who, whether there is actually a causal linkage, because if somebody is in a car accident after they get their vaccine or they get hit by a bus, that's going to be reported as well. And unless there's a direct link to it. So this is why we have the systems, because we want to find out if there are things that the vaccine causes that causes illness or death. So it's a very important question, and we definitely need to keep looking at it. We're not trying to, say that it's not important. It's just the issue of, I'm terrified until I can get my shot, because I know how bad the disease is when 500,000 people in the United States have died, which is more than, World War II, the Korean War, and the Vietnam War altogether. That means that the risk from the disease is just so much greater. And then, but people will follow up on these deaths, and that's why they're reported, to see if there is a causal linkage.
Okay, great, thank you. And I know we are ending time, so I want to thank our audience for great questions and asking some of those questions, because this is why we hold programs like this, so that you can come and ask those questions that that you are concerned about. And we really appreciate our panelists and experts. And I guess I would just, if you have any last, comments that you'd like to share, we'd certainly hear any parting words from our panelists. We haven't covered that you were hoping to to get to.
Yeah, I can start. I just wanted to point out something we've been seeing in a lot of our communities, and that's a lot of misinformation. And I want to really try and point people to trusted sources. I think the CDC, WHO, your local governments, your states, and the federal government right now are good sources to be able to get your information with regards to the vaccine. I think speaking to your personal physicians is also important. Joining community groups and meetings like this to further educate yourself can help. But there's quite a bit of information and misinformation that's going around, and it's very understandable that people get confused. And that's why health professionals, public health professionals, are really trying to step up to fill that gap and try and point people in the right direction.
Thank you very much.
I'd just like to say thank you to Amy and Melissa and your team. I've been, and the audience, because you guys have asked great questions. And I think that this is so important, because this isn't about pushing vaccines on people. This is about, okay, it's very good to be skeptical. It's good to ask the questions. But then, as Dr. Hazel just said, you have to actually make sure that your sources of information are correct. And I've actually found sometimes even the sources that try to be really careful, they misinterpret, or in trying to simplify information, it gets said in just slightly the wrong way, which then is confusing to people, because they didn't mean to be misinforming people. Sometimes people do mean to misinform people, but at any rate, so I just want to say thank you to you. Thank you for, to Drs. Hazel and to the audience, because I just found this to be a fascinating discussion. Thank you.
Great, thank you very much. And Dr. Cynthia Hazel, we'd love to hear from you. as
Sure.
well.
Thanks, Amy. I think I always get very excited that, platforms such as yours is being used, to educate people, to disseminate information, because as quickly said before, I think misinformation has been a huge barrier to um, the COVID vaccine rollout, and in our community, especially where the diverse backgrounds come together, lots of cultural values coming together with all of this misinformation has been quite difficult, for people to filter through and get to the accurate sources. So our role here today, and with all the educational campaigns that we've been embarking on, is not to insist that you take the vaccine, but our job here is to ensure that whatever decision that you come to, it is your body, it is your risk, it's your decision to make. But we just want to ensure that whatever decision you come to is based on accurate information, and that whether you decide to take the vaccine or not, that is fine. You just want to make sure that whatever is informing that decision is coming from accurate sources.
Thank you so much. And there's been a lot of thank you comments in the chat. So I know this has been a very informative program. I've learned quite a bit this evening. So I really, again, appreciate our panelists, appreciate our audience asking great questions. For more information, we've been sharing information in the chat about some resources that specifically answer some of the questions, as well as then we did compile a resource guide in preparation for this conversation. And so you can find that on the ppld.org website. So thank you again. We hope you'll join us again at our next community conversation program, or check out ppld.org for some of our other upcoming events. And thank you again. And thank you to our panelists.